Thank you very much for coming, and I'm sorry we've kept you waiting slightly past. And also just to note that in about 20-25 minutes, unfortunately, we're expecting a division, so we may have to temporarily break. So apologies in advance for that. Anyway, so welcome, and I'm just wondering if you would like to start by introducing yourselves, perhaps starting with you, Sir Nick.
I'm Sir Nick Partridge. I'm a non-executive director of the Health and Social Care Information Centre, and previously, up until the end of October last year, I was chief executive of the Terence Higgins Trust, the HIV and sexual health charity, for which I worked for almost 30 years, and I was chief executive there for nearly 25 years.
I'm Kingsley Manning. I'm the chair, as of June last year, at the Health and Social Care Information Centre.
Thank you.
And I'm Tim Kelsey. I'm National Director for Patients and Information at NHS England.
Well, thank you very much, all of you, for coming today. If I could perhaps kick off with you, Sir Nick, that in your review you talk about how in future you must be able to show that your controls are meticulous, foolproof and solid as a rock. Could you perhaps set out for us how that trust can be regained? I mean, particulars in your report, rather worryingly, you identify organisations you identify cases of data releases where it can't be traced, nobody knows where it went.
Of course, I hope that my report is the first step in rebuilding patient and public trust in the Health and Social Care Information Centre, in the care which all parts of health and social care and every data controller, be that within health services or local authorities or the private sector, all recognise their duties and the vital importance of protecting the confidentiality and security of patient data. So if I may, Chairman, can I just take a slight step back and put the findings of the review into their broader context. Firstly, my review and obviously the much more substantial piece of independent work undertaken by PricewaterhouseCoopers was looking at one small part of what the NHS Information Centre did during its lifetime between 2005 and 2013. It was specifically to look at the major data releases where there was either pseudonymised or identifiable data. Obviously, any identifiable data would have got through Section 251 approval, but it was looking specifically at that. It was not, my report was not a history of the NHS Information Centre. It did not cover all of the very good work it did in highlighting and identifying issues of concern to health and social care. It did not cover the over 1,000 reports that it published on broad health issues in tracking, say, the changes in mortality, in tracking what we all talk about now, the ageing population, the growth in diabetes, the issues around obesity. All of those were the subjects of reports that the NHSIC delivered during its lifetime. Similarly, my review did not cover all of the broader issues about changes in informatics, changes in technology, the growth of big data sets, and nor did it look at the real pressure that the Information Centre was under to deliver as much data to as many people as possible. That was out with what we were looking at. What we were looking at specifically were the processes and procedures that were in place to guard and protect patient data, but also to make sure that it could be used to the benefit of health and social care, be that in research or in the design and understanding of need for services now and in the future. So within that, you're right, what PricewaterhouseCoopers found was that the information governance arrangements, the processes and the procedures, were not followed as well as they should have been. It did find 2 instances where they could not, on their deep dive, find out where that data had gone. I'm pleased to be able to report to you, as I did on the World at 1, that both of those data releases have now been resolved. One was an internal issue where the request was originally not properly marked up and then could not be properly chased as a result of not having the right name in it, but actually data did not leave the information centre. It was an unresolved case and should have been closed at the time, but was not.
I'm sorry, can I just clarify? So somebody requested data and it wasn't released?
No, it was an internal generation
yes.
Of a request for data that it thought was going to come in, and it didn't. So so nothing happened.
There was no request.
So yeah, and it just did not go anywhere.
This was under the time period when Northgate were processing the data, and they created effectively a data release record in error. And we've now confirmed that with Northgate. There was no data release.
There
was no data.
Right, okay.
The second was for the purposes of cancer research. And there the issue was about the named individual in the PCT, where there was a slight difference in her name. There was a phonetic difference in the name. And that has now been resolved and identified, and the right processes and procedures were in place. So there is no instance now where the IC, or where now we, as the HSCIC, cannot trace where data went. And you will have seen that attached to my report is the full listing of the 3,059 data releases that the information centre made. So every single one which contained either pseudonymised or identifiable information was identified and has been listed and is in the public domain. So if anyone is concerned about where did their data in anonymised or pseudonymised form go, they can look at that listing. I think the other thing, of course, I'd want to raise is the 9 cases for research where we found that because of changes in the law, changes in legal, that they were no longer properly authorised. And you will find details of those in the appendix, but I thought it might be helpful for the record to remind us of what those 9 studies are, because they are important. And certainly I was concerned in undertaking this review that the purpose from my perspective is to ensure that data which can be so rich is used to improve the health and social care of people in England. I know the importance of that from my work at the Terence Higgins Trust, where data, personal data, is highly sensitive around HIV and around sexual health. However, I also know that without really good epidemiological data, we would not have understood the rapid spread of HIV, the way it impacts on particular communities. Without the enormous research effort across the Medical Research Council and across industry and within universities, we would not have seen the development of drug treatments which keep so many of my friends and colleagues alive today. So I'm crucially aware of the very real difference research makes in a whole range of areas, be that in how services are designed and delivered, how they're funded, how we understand future trends, and so on. So I thought it might be helpful just for us to remind ourselves of these are 9 where sadly the ONS gateway was not properly in place. This is they were suspended because they're all historical studies that were originally fully covered by Section 60 of the Health and Social Care Act of 2001, but their approvals were not updated following a legislative shift in 2006. So they include the Institute of Child Health with a study to track and report on patients who have received or who are currently receiving growth hormone therapy. There's the University of Cambridge with the European Prospective Investigation into Cancer. And this study investigates the link between food consumption and cancer. There's the University of Oxford, the Oxford Register of Early Childhood Impairments. And this study uses information for planning services and support for children with disabilities such as cerebral palsy, deafness and blindness. There's the Imperial College Healthcare Trust. There's a study, it's a longitudinal mortality study tracking patients undergoing cardiothoracic surgical procedures at Hammersmith Hospital. The University of Oxford.
Nick, could I stop you there? Because, so you're satisfied that all of these were for bona fide research purposes?
Yes.
Perhaps you could supply us with the list.
Okay,
Can
I will
just
provide you with this.
referring to the point you made earlier about the importance of research to the Terence Higgins Trust and those who the Terence Higgins Trust represents, do you have some concerns then about data about sexually transmitted infections being excluded from care.data?
I know that my colleagues in National AIDS Trust have recently produced a report which I would happily send to you or ask National AIDS Trust to send to you, where they raise exactly that point, that there are issues specifically for HIV around how is there going to be any significant disadvantage to people with HIV because data is not being collected. And I know that Tim has heard similar concerns being raised by other patient groups around mental health, for example, and what's collected within GP records. So there's a wide range of patient opinion, and people with HIV expressed this very clearly to me when we were looking at the development of the summary care record, which, of course, the summary care record, as you will recall, has the particular medications on it. And, of course, if you're on AZT or on Truvada, then there is only one thing you can have. Yes. And there was a split in opinion between those people with HIV who absolutely wanted that data on their summary care record in case they were in a different city, they fell ill or had an accident and ended up in A&E, and they wanted those doctors to know the medication that they were on. On the other hand, there were those whose fears around confidentiality and anonymity were so great that they were prepared to take the risk of clinicians not knowing what treatment that they were on. So there's that range.
So there's a range. Thank you. I'm going to bring Barbara in. It's Barbara Keane.
Thank you. And I can understand you talking about research organisations and the importance that data sharing has to research, but I'm afraid that's not the problem with the public. So I think it would help us today if we moved off the things which the public is reassured about and moved on to the things that the public is not so happy about. I think the language you used is just at the pinnacle of understatement, actually, because I used to work in IT for a number of years, and I think this is the most appalling mess. One of the things I really wanted to take issue with you is that you say that no individual has ever complained excuse me, that their confidentiality has been breached as a result of data sharing. Now, you make that point about the NHS Information Centre, but individuals have complained, and I received a number of comments on social media from people who have put in complaints, and I'll mention one or two cases. It's been raised that there was a very serious case in 2005 when the HSCIC was going, the case of Helen Wilkinson, which was debated in this House. Her records, this is an example of the things that can go wrong. Her patient records had a wrongly coded piece of information that recorded her as an alcoholic and having had treatment as an alcoholic. She was an NHS practice manager, so she was very, very concerned, having a career with the NHS, that incorrect information had been recorded about her in her records from UCL Hospital and then sent to a private company that was accessing those records. So in the very earliest days of this activity that you're talking about in your report, there was an absolutely profound example of what can go wrong. Now, I think, given that example, that one example of what can go wrong, of course, other people have concerns too. On the point you were just making to the chair, I've had a very heartfelt note from a patient, nothing to do with me as an MP, who said that he had gone to his doctor that day and not told the doctor the full facts about himself because he was so concerned that what he wanted to say or would have said would find its way into the patient record. The case of Helen Wilkinson, she withdrew entirely from the NHS so that all her records were being cancelled. This was a big issue that was pursued in this House and in Downing Street in 2005. So it isn't the case, and I think it's inappropriate to say that people have not complained. I heard yesterday from somebody who has complained to the Information Commissioner as a data subject, and he made a complaint about the release of data and health records to insurance companies, which we've talked about in this committee a few months ago. And in May 2014, the Information Commissioner told this person, who's called Mr. Baines, "We are already aware of the issue and are investigating. We do not necessarily require individual complaints to consider taking further action, and your case is closed." So the Information Commissioner isn't even looking, for whatever reason, and that might be something we want to look at in terms of individual complaints. So I think that language that you've used is really inappropriate. A number of people, a number of organisations have made complaints about their concerns, and it's not going to help building for the future if you make those sort of statements.
I hope I was clear in my report that I was reporting the facts as I saw them. It was not to deny or in any way understate the very real concerns, as I was talking about around the summary care record and some people with HIV, about where data goes. So my apologies if you felt that it read that way. I hoped that the other parts of my report
I can understand that you were trying to be reassuring, but I think for the sake of your colleagues, for the sake of taking this work forward, then I think you have to acknowledge, you really do have to acknowledge that there have been some serious issues. You see, the point about the cases like the Helen Wilkinson case, okay, it's a really bad thing to have a miscoded record in your patient records. It starts to become a problem when it's shared. If it was just in your GP record, then it isn't quite of concern. You know, what most people trust their GPs, most people trust the practice they attend. You're actually, through your organisation, sharing data with insurance companies, with all kinds of private companies, as you've listed in your report. That's where the concern comes in. And it doesn't help, in my view, to gloss over the incidents there have been and the fears that people have had and the concerns that they're trying to put to the Information Commissioner, for instance, about releasing records to insurance companies, by saying no, it's a fact that no one has ever complained, because you fly in the face of somebody who's given up being an NHS patient because of what happened to her records. That's a very serious case. And if you don't know about that case, I recommend that you all look at it, because it's quite an important one. Can I take you up on another point that you made? You have just repeated the point that you made earlier, that people can track where their data went. If they're interested in where their data went, they can look at the listing. That's the point you make. And it's good that we're finally starting to get these lists of where the data goes to. But I want to talk very briefly about reuse agreements, because in paragraph 29 you say there's a confusion regarding the difference between a data sharing agreement and a data reuse agreement, and in what circumstances they were appropriate. I've, in debates in this House, talked about commercial users of our hospital data. I've quoted to ministers companies like Harvey Walsh, companies with tools like Omega Solver, a comparison website, private company that developed and was given access recently. Those companies have actually said, one of the companies, Harvey Walsh, said it had more than 1 billion linked patient records. Those companies have said they have the ability to track patients over time. They have said they have tools that can track patients through their hospital care. Now, clearly, that's a very frightening prospect. It's not a frightening prospect if you talk about research done for medical reasons by the charities you've talked about and the hospitals you've talked about. These are the things that frighten people, and I didn't have any satisfactory answers when I put these in front of ministers. And I think I really do advise that we start to get some answers about this, really, because we've got a question later about the insurance companies, but we're not getting to the bottom of where all this data is going. We're really not. And I think there are questions like which companies and which data releases were actually done under commercial reuse licenses, because you still have those. You still have licenses and agreements with organisations that can then sell the data or move the data on, and they have applications to do that. So I just think right at the outset we need not to have this honeyed view of a few little glitches here and there, but some very serious things that these are the things that people worry about, and I want to know that those issues are being recognised.
I accept and absolutely have no complacency at all about both the seriousness of any individual data release, and I go back and I thought right from the start of my report where I said that it is patients and the public data we guard, and it is their trust that we must earn. And that's the basis from which I went. And
okay.
So I accept your comments.
So I'll end now, Chair, with this point I'm making. Can you then give us a list of this committee, a list of which companies and which releases were under commercial reuse licenses? Did those companies, because it seems that the NHSIC didn't understand the difference between its own agreements and its different terms and licenses, and can we be assured going forward that, as the recent legislation has said, data will only be released for the NHS and care? And, I will come on to questions about the insurance companies later, but we absolutely need to know that. But to be comfortable, we need to know where data has been released to. So where is the list? And I've asked questions about this. Where is the list of companies who can then release data onto other companies or individuals?
Perfectly happy to provide you with that list. To clarify the situation, we're currently reviewing all outstanding data agreements with all recipients. There's 777 of them, and all of them are required.
Sorry, say again. You said that very quietly.
There's currently 777 extant data agreements. All of them are going to be subject to reapplication process. Are currently going through reapplication processes as we speak. It'll take us about 8 months to do that. They will be required to change to enter into a very new type of agreement. We're going to have data sharing contracts.
Can I ask you just to speak up?
I'm so sorry. We're equally having difficulty hearing you. So, I will lean forward and attempt to shout. I'm sorry, Chairman. There's a sort of buzz from behind, which is very distracting. We absolutely taken on board your concerns. We are renewing and reviewing all of the outstanding agreements. There are 777 of them. We're doing that over the next 8 months. They will all be required to reapply. Their reapplications will require a much more extensive declaration of information. All of the applications will be reviewed by the Data Advisory Group. And of course, we will be applying the CARE Act even before the regulations come into place. We will be applying the Act as it sets out in terms of not for wholly commercial purposes and for the benefit of the health and social care system. So we will be applying that process. We will make that very transparent. All of those agreements will be available for public scrutiny. And then following that, and the data sharing contracts will have an upgraded requirement with regard to audit, declarations and so forth. Equally at the same time, for each individual data release, they will be required to enter into a data sharing agreement. So we have a contract with an organisation, and then for each data release, each of the data releases will be reviewed by DARG. They will all be on the public record, and they will, in every case, require clear a statement with regard to any reuse and purpose, which will also require that there is a deletion of any data that is passed on under a reuse agreement, and also the right to audit.
And will that apply retrospectively? Because you're talking about how it will be, and that will be good. But what about the past?
We are currently there are, I think, 596 agreements that have ceased following the IC. I think that the precise number, I think, is that. We are in the process at the moment of contacting all of those organisations where agreements have ceased to require deletion and certification of deletion. We think that process will take about 6 months to do, and in parallel with that, we will start audit process, in fact, this month, next month, I think, end of this month, so that the threat is, not threat, but we will follow up the requirement of certification of deletion by audit.
Thank you. I'm afraid we are just going to have to take a break there, and we'll be back shortly, so apologies for that.
I didn't hear.
So we're going to start. So I'm just going to bring in David Tradick for the next question. Thank you very
much. Yes, the overall impression I get at the moment is that you feel everything's fine, and we feel there are things we haven't really heard about. And I'd like to ask you, have you identified how the failure to properly authorise the 9 research programmes came about? Have you identified how that failure came about? I think, Sir Nick, in fairness to you, my recollection is that you went through a list and explained that there was a muddle over names and there were various other things. So are you quite satisfied that you've identified all aspects of this failure?
Yes, I am. I think the work that PricewaterhouseCoopers did, which was extensive, it used their standard methodology, looking in depth at 10% of the 3,059 data releases the Information Centre made. And where there were issues that were raised which required a broader look, and in particular the 9 research programmes are an example of that, where spotting one, they said, okay, this is serious enough, we should look at all within the medical information research services. So that's what they did, and that's why we know that there is that issue, which, as I say, is a result of changes in legislation which were not picked up at the time that they should have been. And it is now up to the ONS to make the appropriate gateway approval. Those approvals are underway, and I'm led to believe that they will not be they will be retrospective, so the research will not be damaged.
So is the ONS legal gateway then? Is that you seem to be sort of saying this is an arm's length situation? So if they authorise it, then it's really their problem rather than ours.
Because these studies are looking, as I said, on mortality data, this is ONS data. We distribute it to these studies on the ONS behalf. In 2010, there was a change which required a resubmission of all the people with this gateway. So these 9 organisations were left off the list. It was an administrative error.
Right.
And so we then spotted it in part of this review. So we know exactly why it arose.
It's a simple statement, but it has an enormity about it. So how are you going to make sure in the future that there aren't simple administrative errors as you describe them?
Well, first of all, can I just comment on your opening statement about the fact that we're complacent? That's absolutely not the case.
I didn't intend to insult you. I said that the impression was that you felt that everything was all right. I can assure you that I and my board and our main management team do not think that's the case at all. Right.
When we
that was the impression.
I'm sorry if
it's an opening statement, and I said the impression on this side of the fence was that we definitely felt
we were very clear.
To my colleague Barbara Keatley official.
Yeah, we were very clear as a new board when we took responsibility for the IC that everything was not right, and we put in hand a series of management changes and a series of process changes, which started in June last year with reappointment of management. One of the obvious failures which this review found was that the responsibility for managing releases with the Information Centre was diffuse, disaggregated, and it was not consistent or robust. We have reorganised it such that there is a single management structure with a single responsible senior manager to the board. We have ensured that all data releases are reviewed by our advisory group, so they're all processed in the same way. We are assuring that they will all have their agreements go through a process of reapplication, so that they all have the same data service and so forth. So we're installing a CRM system to ensure we track all of these things, and we're publishing all the information. So we've put in place a much more robust, much clearer process across the whole organisation.
Thank you very much.
Deeply concerned about it.
I think the thing that surprised me more than anything was that there was not one clear, simple, effective and transparent process for the management of all data releases. And there were, after all, 3,059. It's not beyond the wit of man to list all of those one by one, but that is not what had happened. It is what will happen in the future. There is one way in, and it will be tracked throughout that, from the request through to the deletion of that data.
I mean, it's staggering. I mean, you describe it as diffuse, disaggregate, not robust, that kind of sloppiness from an organisation that is controlling IT. I mean, did that shock you deeply?
Yeah, as I said in my report, there were areas which concerned me. I thought it was quite a hard-hitting and open report that laid bare the issues that we had seen within the narrow scope, of course, of the data sharing agreement, in order that the new board and management team could draw a line in the sand and to begin to rebuild patient trust and confidence in the use of their data. Clearly I was not tough enough.
Now, I can see that both Rosie Cooper and Charlotte Leslie want to come in on that point with a quick follow-up.
Thank you. Forgive me for joining you late. Using the description that you've given, do you not think that fining people for breaches is not good enough, that be for industry or indeed for holding your good selves to account? And that the only way that the public are ever going to get real confidence that you are engaged and absolutely committed to their confidentiality in using this system properly is if this and the use of the system in the way that you outline becomes a criminal offence and people could go to jail for it. And I actually would like to see some of you held to that level of account, because what has gone on is a disgrace. It is our information. You sit there and it's all very jovial and you laugh when we sit and read in the newspapers just what has happened to our information. And so Nick, you said that the ICO said nobody had reported any breaches. Okay, sorry, but nobody had reported any breaches. Let me tell you, I did. And what they did tell me to do was to go back to basics and start complaining from the bottom upwards. So it's not true. You cannot just run and hide. This has to be a criminal offence, and you won't have people's confidence in you until you are actually at risk because of what you do. Not money, because the taxpayer will end up paying for it. You have to be on the line.
Would you like to respond to that point?
I'm afraid, as I replied, I think, to the same question last time, the question of criminal offences is not one within our gift, and is a subject for yourselves in terms of Parliament. I have to say that we, and I think you'd find the ICO and others would be sympathetic, not necessarily to criminal offence, but perhaps that the issues with respect to sanctions are inadequate. We might well be in a position where we might support that view. It's not something we have any control over.
Thank you. Could I bring in Charlotte Leslie?
Thank you very much. I'm sorry for rejoining the session late. I want to take us back very quickly, and if we could make it quick, because I know we were limited on time, to the nine cases, the 9 research programmes which hadn't been properly authorised. And so you've begun to listen. I think we've done Imperial Healthcare Trust, and you're on number 5. Can you just very quickly run through what the organisations are that were running or were
very briefly, the others were the University of Oxford, the University of Birmingham, twice, University of Cambridge, and the Institute for Cancer Research.
Great. There's one query I have, and the reason it's interesting is not only for this specific case, but because of what it might tell us about other cases. The What About Youth survey that was undertaken in November 2013 to February 2014. I asked some parliamentary questions about this. It emerges that the What About Youth survey did not have support under Section 251 of the NHS Act 2006, nor was it listed on the list of data release, as far as I can see. So here you have something that was data collection from young people that was done without legal support, that wasn't on your data release. Now, I only got it because I happen to know about this myself. And I asked a parliamentary question and then was assured that the data was now deleted. I'm yet to find out when the data was actually deleted. How can we be sure that the list of data releases and any information that's in the public domain is in any way complete? Because this doesn't appear to be on it. Now, if it is on it and I've looked over it, my full apologies, and I'd be grateful if you could point it out to me. But we don't know what we don't know. And this would have been one of the things we didn't know unless I had known about it from another source.
I mean, clearly, my report and the PricewaterhouseCoopers review was into data releases by the IC. What you're referring to is a data release by HSCIC because it's post April 13. So,
I'm aware of I've seen details of your parliamentary question this morning. I can confirm that the reply will, in fact, say that the information has been deleted. My understanding, and we will confirm this when the answer is written, is that the study never took place, that the initial work was done in terms of setting up, looking at methodologies. It didn't receive 251 clearance, and therefore the initial methodological data was deleted. The study did not proceed. But we will confirm that through the normal challenge.
Tim, can I come to you? What reassurance, because a lot of this is about public reassurance, because I think most people agree that there is a very valuable place for data collection and research. What assurance can you give us that the incident that I've just cited is a complete one-off? Because it doesn't seem to be like it might be, or there aren't other incidences where studies do go ahead and that the data release list is complete.
As far as I'm aware, there was never a data agreement in place and data releases did not occur under 251.
Okay.
It would have been illegal for us to do so. Okay, we will confirm that. So it's not a missing study.
Okay.
Right.
Thank you.
Any comment on that?
I don't really, in a way,
except
to say that NHS England is in a position where it, from time to time, will issue directions to the Information Centre on the basis that the data that is subsequently collected on its behalf is subject to the rules that Kingsley just described. So I'm unaware of any situation since April 2013 in which NHS England I can speak to, in which any data would have been collected without being subject to the rules that have just been described.
Thank you.
Thank you. Now, can I move on? Because I'm quite conscious that we're a bit pressed for time. Andrew, I think you were coming in with the next group of questions.
Yes, well just in terms of the data sharing agreements, I mean, there were four with three reinsurance companies, and there was clear indication that you should make clear to them that they delete the data that they were otherwise able to use up until 2015. I just wanted, in that particular case, particularly in relation to the provisions under the Care Act, what communications you've had with them, and whether you're confident that they have acted on what I assume must have been by now your instructions.
Okay. Yes, I can. I can give you an update as to where we are. You're right. There are three organisations and four agreements. The first with SCOR, who's a reinsurer, that's spelled SCOR. We were asking them, are they planning to continue using their data? SCOR is planning to do so. Are they going to delete data? No, they are not. Are they going to terminate their data sharing agreement? No, they are not. Do they use the HES data, the data that has been released for individual insurance purposes? No, they do not. For RGA, the reinsurer, they are no longer, or they're not planning to continue using their HES data. They are going to delete that data, and they are going to terminate their data sharing agreement. And they too have confirmed that they did not use the data for individual insurance purposes. Milliman is slightly different. It's a consultancy using HES for NHS customers, and they are going to continue using their the HES data for that, and as a result, they're not going to be deleting that data until the end of their agreement. And they are going to, and they're not going to terminate their data sharing agreement. They have a wish to expand their scope to include a cancer research project in the future. As I say, they're very different. They're not significantly around insurance, and because of that, they of course did not use data for individual insurance purposes. Further and above this, we're in discussions with the ABI, the Association of British Insurers, to find ways of meeting the requirements of the insurance industry through the provision of anonymised data only. There is a belief that much of this can be done using anonymised data only. And of course, it is important to remember that when anyone looks for health insurance, they would give consent for their individual record to be used in that way. But at the moment, that's the position.
So, but you've simply asked the question. There's no indication there there's been any instruction to delete.
We don't have these were legitimate contracts.
Not even under the Care Act.
No, not under the Care Act.
The provisions of the Care Act. So all you're doing is you're collating information on their plans to either use, delete, and in future manage the use of it.
They will have to go through a process of reapplication. That process of reapplication will be subject to the advice offered from CAG in accordance with the Care Act. And the Care Act is clear; it's health and social care benefit, and not wholly commercial. So we will be applying that test to any process of reapplication.
I mean, how do you know? I mean, they got this data up until 2016. Another 2 years, they can do what they like, can't they? I mean, you're not watching them all the time. I mean, how can you possibly know?
Because as far as the data releases that they have were legally entered into and are proper and appropriate.
Yeah. Said who?
Just finish.
Okay. Yes.
And we suggested to them they may wish to. We wish to gather further information about the use, and we've identified the use does not include, and indeed it would be illegal for them to use the data to set individual subscriptions for insurance purposes. And we believe, and my understanding at this stage is that their current use would still be in line with the Care Act.
But of course, there are other ways in which they can use the data to inform how they might treat kind of groups of patients for the purposes of their reinsurance, not rather than individuals.
Yeah, we're very enthusiastic and keen and very supportive of the notion that these matters need to be considered by the confidential advisory group. We've identified four typical examples of where we need the CAG's advice, and so we're absolutely clear that the individual use of this data for individual insurances is totally out with the legislation. That the use of it for for example, looking at the effects of chronic illness or life expectancy and so forth across an insurer, we believe is within the current legislation and indeed within the Care Act. But we will be asking and expecting that CAG will provide us with advice on this, and we'll be in discussions about, we have already started discussions with HRA, the Health Research Authority, and CAG about doing precisely this ahead of the regulations.
I mean, isn't the problem with this system, it's a bit like letting genies out of bottles. Once they're out, there's virtually nothing you can do.
They under the arrangement, they have to state the purpose for which they're using the data. That has to be clearly stated. Yeah. If they then use the data for any other purposes, they would clearly be in breach of a data sharing contract. And my understanding is there is discussion that if they would discover, if that became apparent, and we are going through the process of auditing these people, then there is the potential of withdrawing the data, and indeed one striking out is the presumption. Yeah, but it
sounds a bit like a paper tiger, really, because I mean I'm afraid that a lot of the evidence, the review and your own report, Sir Nick, it seems to indicate that with the best of intentions, you haven't lived up to the kind of narrative you've just described. In other words, you haven't successfully regulated or imposed or monitored the management of data, and there have been lapses, and there are clearly issues which still need to be resolved. So, I mean, we have a system which clearly is not being adequately monitored and regulated. So I can't see how you can speak with such confidence on the matter.
Well, I'm not. Neither am I complacent, nor am I defending the process that we inherited, and we are in the process very clearly of putting in vastly greater, transparent, publicly scrutinised processes to improve the position.
I mean, we'll come back to the issue of to what extent some of the old guard are part of the new guard, and whether people can wash their hands of the past. But with regard to...
We're making no attempt to wash our hands of the past. Indeed, we've taken full responsibility to sort out the mess.
All right, well, we'll deal with that as a committee as well. But, I mean, in respect of just taking this area of data sharing, and this is asking perhaps all three of you for with the benefit of hindsight and on reflection, whether it wouldn't be better to have a system of data management which involved any external organisations which wish to undertake any kind of research or had questions which were legitimate, for which the data provides a very useful, a very useful source of information. Wouldn't it be better if you held on to that data, that you received those questions, you undertook the analysis, and then provided them with the answers, rather than releasing this genie from the bottle, from which I'm afraid we don't seem to be able to manage?
We would be in agreement with that. We already have a data lab service available for some NHS customers. That's in development. In the case of care.data, we are specifically only going to put the data available in what we call a data lab environment. Okay. And we're in discussions with the MRC and with Professor Sally Davis, CMO, about creating a data lab environment for purposes of research. Mm-hmm. So, yes, I think we would believe that would be by far the best way of approaching it. I wouldn't wish to underestimate both the technical challenges of doing that and the investment case. But we would entirely agree that would be an appropriate solution. In the meantime, we have a very large and significant research industry and health and social care system which still need access to the data. So we have to manage it in that transition period.
But the resource issue, it doesn't take an Einstein to work out that you've got something extremely valuable for which people would be prepared to pay money in order to get that information. Therefore, if you don't have the resource, then if people pay the money, you can undertake that research for them for a cost, and one assuming that you have. Oh, sorry, I am.
Later.
Okay.
Yes,
I do beg your
I'm just
pardon.
wondering whether we could stick with the original part of the report.
I will finish there, and we're coming back on to that. I do beg your pardon.
Why you didn't do if using a data lab is a way out? Why did none of the geniuses sitting before us think of it and do it before, unless they had a callous disregard for people's privacy?
Because technically it's very challenging to have done it historically. The way that
too hard.
Well, I'm sorry, Mr. Cooper. The practical reality was that when HES was started, in fact, data was distributed on 5-inch floppy disks. We have moved on to a situation where now the cost of storing and processing this data means that the data lab solution becomes a feasible proposition.
Can I tell you, Rosie, hang on. People's personal records are invaluable to them.
Rosie, can we, we have actually covered a lot of this at the beginning. So I'm going to move on to Barbara Keeley, and I know the issue of data rooms is something that I'd like Tim's opinion on, but we've got a specific session of that later on in the end. So perhaps, Barbara, I could return to the subject of the Price Waterhouse review at this stage.
Yes, indeed. Can I just be clear on the point that you've made, because I think this has been quite an important development in this committee meeting, that in terms of the report you gave us, you said that the HSCIC chief executive wrote to the 3 companies concerned asking them to delete the data ahead of the legislation coming into force. You're now saying to us that you don't have the authority to do that. You found you had no authority to instruct insurance companies to delete the data. But presumably you thought you had when you wrote that report.
I'm not clear where you're quoting from, because
I'm quoting from paragraph 27 of the report. I ensured that the HSCIC's chief executive wrote to the 3 insurance companies concerned, asking them to delete the data ahead of this legislation coming into force. What you've just run through is that you didn't. That isn't what happened. What happened was that they've said they're going to carry on using. I confirmed
that we did indeed write to them asking them to delete the data. What I made clear is that we have no power to require them to delete the data. We did indeed invite them to do so.
I have to tell you then that I think that's an issue that for this committee, because I was in the debate with the Minister on the amendments that were being made to legislation, and the Minister was clear, absolutely clear in what he was saying, that uses in future would only be for health and care. So if you're saying to us that it's permissible to carry on with insurance uses, commercial uses, And there are other companies than insurance companies. I mean, I have to say to you, in terms of what people are concerned about and what will cause them to not be frank with their doctors and to worry about or withdraw themselves from the NHS, like the example I've given you, it's this sort of thing. People don't want their data sold onto marketing companies or insurance companies or go compare websites, which is something that you've done in recent months. They don't want that. They trust their GPs, they trust, for the most part, their hospital doctors. And I think if you know, somehow this doesn't seem to be getting through because you've almost glossed past the point where you've admitted to us that you can't go back to them and instruct them to delete that data. This question of audit of deletions of data is very important. So I think there are 2 points. The one I've already raised about data reuse agreements and who is the end user, but your authority to do this, and maybe the chair might say we could take that to minister.
Yes, and what I'm wondering is, could you just clarify, you said the first company was the one that has said that it intends to carry on using the data, it will not delete it. Could you just remind the committee the name of that, because you've very softly spoken and I didn't catch the name of that first company you referred to.
SCOR, who are a reinsurance
right.
company.
And so you're saying you have no powers to request them to delete it, and even within the terms of the Care Act, you believe that that would be legal under the Care Act?
I am advised that we do not have the powers to ask them to delete the data under the current data sharing agreement we have with them.
And that extends to 2016?
We are awaiting the announcement of the regulations with regard to CAG, and I believe that they will be laid before the House in September. We have asked CAG, working with CAG, to look at these cases such as this so we can have an early indication of how CAG will view these. And I understand and am advised that the Act says that the use of the data has to be released for the health and social care, advanced health care services, and not for solely commercial purposes. Right. That is the current position. We will be governed by and have to take into account completely the advice from the Confidential Advisory Group.
Thank you.
And that where our future decision making will be subject to their advice.
Right.
You told me earlier that there were, I think, 771, if I've got that number.
777
current data reuse agreements, and you agreed to list those organisations that had those. I think we need to understand the nature of those organisations, because it may be that this goes beyond insurance companies to other companies that have not got a health or social care remit, having the ability, because they have an old data reuse agreement that can run on. So we need a list of all of those.
Yes, I mean they're all listed in both in Nick's report and in the register we released in April, and we're updating the register tomorrow. So they're all actually not only details of organisations, but the details of purposes in ones that we've been involved in, and indeed the data releases are all being put into the public domain.
Let me move on. I do think you need to understand how important this issue of audit and deletion of data is to the public. So Nick made 9 recommendations in his review, and Kingsley Manning has told us that they were all accepted, if that aspect of your report is accurate, whereas others don't seem to have been. Do you have a timetable for that implementation? Because you didn't give one in the report.
Yes, once the board had approved, had accepted the recommendation, there is an action plan with target dates and with progress, and the target dates zipping down this.
Could you just let us have that? I think.
Yes, I'll let you have it.
Absolutely. And to say what we've also said is that we will publish an update on the implementation of those recommendations at each of our public board meetings going forward.
Okay, so but that hasn't been made public, has it?
Yeah, sorry?
That hasn't been made public, and it wasn't sent to us.
It would have been it's in our board minutes.
It's in our board papers.
Okay, but it would have been helpful if you'd sent it to us, I think. Could I just ask a small follow-on question from that then? There are various developments at the HSCIC, things like accrediting safe havens. Given what has been said by this committee again today about the lack of confidence in your progress, and I have to say, I remind you that you've taken across from the NHSIC a substantial number of staff who did work in that old organisation with all its bad ways and all its muddled processes that are described in the report. Is it not the case, or do you not think that you should implement those recommendations first before you start moving on to new things like accrediting safe havens? I mean, really, there's a stage, I feel, and it might be shared by other committee members, that you've got to do some confidence building before you start doing new things.
I agree with that, and I think that we are We decided to start publishing the data releases last December. We put that process in hand. We have made major changes to the relevant senior management. So we've appointed Professor Martin Severs as the Court Guardian, who has an international reputation in this area, totally independent. New CIRO.
But the stuff if I could just say, the stuff I referred to, the more junior stuff, I think we can all see that you've changed things at the senior level. But you have hundreds of people working at the HSCIC that were part of all of these bad old ways, and they need to change what they do.
I agree with that.
If this sloppiness that's apparent in this report was allowed for many, many years in their old organisation, they need a bit of time to adjust to a new regime.
Actually, it's not hundreds of people. The numbers of part of the problem here was that there was a lack of resource devoted to this area. So, in fact, the core team was only 27 people. We put an additional 20 people into this resource area to deal with the issue of data releases. So we absolutely accept your point.
No, the number of staff that moved across from the NHS Information Centre was more than 27, unless the answers I've been given.
No, I understand that, but we are, for example, one of the largest single employers of statisticians for the official city. They had nothing to do with the data release process. Right. So this is a small part of what the IC did and does. We totally accept the requirement to change culture. And one of the things that PwC comment on was the willingness of the staff involved to become participatives in the review and indeed to contribute. And we are one thing we're absolutely keen on is that, for example, these individuals should come forward and identify problems, issues, and so forth. This has to be a change of culture. Entirely accept.
I know, Nick, you want to
very briefly. One of the things that impressed me as a non-executive director, so I come in and take a clear look at this, is the way in which those who were most impacted by this report were actively engaged within it, have learnt from it, and were indeed themselves frustrated at what they knew were processes were not good enough. What the recommendations do is provide them with a better structure and an end-to-end process that they will be able to work in and work to create that public trust and to do the job that they want to do too. They are similarly absolutely clear about the importance of rebuilding trust. They want to see individuals' healthcare data used in the best possible way, where security, confidentiality is protected, and we can rebuild trust. And that does require the transformation programme that is in place, that there is a recognition of exactly where things went wrong and how those can be put right, and I believe that will happen, and we will report on that at each of our board meetings publicly.
Quite keen to move on to Valerie now, but can I just ask, you mentioned on that last point, you said that staff had concerns. Did they raise those concerns with anyone at the time?
Neither Nick nor I were there. I think that I would not comment that there was...
We don't know. Okay. Problems. Thank you, Valerie. You wanted to come in.
Thank you. And we're obviously all extremely concerned that you had to come back before us. I think if it wasn't the Select Committee actually asking for you to return, probably this report wouldn't have been done. I think we first heard about the breaches in the Telegraph.
I established the Partridge Review immediately after the first. So we wasn't...
Okay, well, anyway, thank you for coming back. And Sir Nick, your report is quite devastating, actually, isn't it? Mm-hmm. And I hope this is in the public domain.
Oh, yes, it certainly is.
So any member of the public can see this report.
The World at One, yes, it's absolutely in the public.
And I suppose what I'm really looking for, and I have struggled to look at it, may be here. I mean, I've read it a couple of times, but I can't see an apology anywhere in this report for what seem to be very serious breaches.
This is a report written about the NHS Information Centre. What I was quite clear about in paragraph 3 is that these lapses occurred before the HSCIC came into being, and so it might be said that they are not the HSCIC's fault. However, that is beside the point. The lapses are very much our responsibility to address.
Of course, and we can always...
I feel uneasy about apologising on behalf of other people.
No,
but
you can apologise for the breaches. You're not apologising on behalf of other people. You're in the organisation now, aren't you?
Yes.
Right. So, well, okay. You don't want to apologise.
For all of where we know that things could have been done better in the past,
yeah,
and where we know that we should have done, I apologise for that. And the commitment that comes along with that is to do it right in the future. And
Good.
I believe that the recommendations and the action plans will put us in a place where we can do that.
Now, just to clarify, because I couldn't hear a lot of what was going, there's a lot of questions forwards and backwards. You've made some very interesting recommendations, and part of what we do is to try to move forward. When do you think those recommendations will be implemented in their entirety? Because picking up some of my colleagues' points, you mentioned that you're at number 3. You want a robust audit function and how data is being used, stored and deleted, which is something that you said you don't have now. You said one data sharing agreement will be developed. Sorry?
It's already been developed, yeah.
Right, okay. So, and what people are using it now?
As I've already explained, we're going through a process of moving all current data agreements, 777 of them, onto the new agreement. That will be completed, I think, we suspect, by Christmas.
Okay.
That process is already in hand.
So you will have the sanctions that you've asked for then here?
We will substantially strengthen the relationship, contractual relationship.
Okay.
And I'm perfectly happy to supply you with copies of the new data service agreement and the new service contract if you were interested. They're quite detailed and legal.
Yes.
I was very keen to ensure that both the review was done in a very focused way. It was a review that was undertaken fast, and similarly I was very keen to ensure that the action points with their completion target date were similarly enacted quickly. The last one is for the 30th of November 2014, so all of the action points should have been completed by the end of November this year.
Good. So just for the record, could you state then, do you have the appropriate procedures in place now so that anything that came out of this report would not happen again?
For the record, I believe that when these recommendations are put in place, we will have a rigorous process which the public and patients can rely upon. Yes.
Can I just take you to your paragraph 24 then? Mm-hmm. And you said something about you took over in June last year. Is that right?
How do you mean?
Well, new board was I wrote down June last year. No, just June last year. One of you said you were all in place in June last year.
Kingsley became chair in June last year.
So then why something hasn't gone through a gateway in 2014?
That was because of the legislative change that took place in 2006. It was not identified until we did this piece of work, the PwC piece of work. So it's not something new in 2014. Sorry.
I know it's not something new, but it's something that happens as now that PwC have identified as happening on your watch, and you said it's not everything is okay since we came into post. So I'm just wondering why this is still going on.
I don't think I said that at all. What I said when I was appointed and Nick was there a couple of months before, we clearly identified the problem.
Sorry, with the greatest respect, I'm not attacking you. I'm not asking you to account for anything. I just want to know. I'm just reading the report. I'm reading the words on the report. I'm just merely asking you the question.
Yes, absolutely.
So that everyone can understand it.
But this is to the issue with regard to the ONS clearances.
Yes.
The original administrative problem occurred in 2010. Okay? That was when the list went off to the ONS, and it did not, as I understand, include these 9 organisations. It should have done. And then it wasn't noticed until this year.
And I suppose that's what concerns everyone. Someone has to notice it.
Yeah,
You're in charge of this all, and you don't notice it, and you haven't got procedures in place to notice it.
Well, I think that's the whole core of this process. We absolutely identified that the procedures were not in place. And we took action immediately and started the process of changing the management, changing the structure, changing the process, which we described in detail, which will ensure this cannot happen again.
No, I understand that, but you had to commission a report to do this, to find it.
No.
You didn't find it through your own procedures.
We had already started a process of...
No, you didn't. You didn't come to us and say, oh, by the way, there's a breach. Something didn't go through the gateway. It had to be PwC who had to do a report before they found that out. You said it. It's your own paragraph.
Yes, that's absolutely true. What I'm saying...
I'm saying it's still happening. I'm trying to tell you it's still happening. They've identified a situation where it's still happening.
We're taking over a situation where we're dealing with hundreds of data releases. We're improving the process as we go along. We're grateful for the focus that the committee gave us on this, and clearly we will constantly be trawling through all our systems and all our parts of organisations to identify where there may be past problems. Indeed, one of the things we're really concerned about is to encourage the staff, encourage people in the organisation to come forward with issues such as this. I may also say, by the way, that the 9 organisations themselves hadn't noticed that they were no longer authorised.
It's okay then.
Right? So, I don't. That's no excuse at all.
This, so.
But and indeed, the authorisation was ultimately to do with them as much as it was for us.
Okay. So, can I just turn to paragraph 20 then? And can you just explain what this outsourcing to Northgate is? I have no idea what the company is, what it does, and who they are. So could you just explain what the procedure is when you outsource?
I'm perfectly happy to tell you what I know.
Yeah,
but clearly, but this is a long time ago now. And between us, we may be HES was originally run internally by the Department of Health, and it was, I think, at that point outsourced to Northgate. Northgate are a data processing organisation,
right,
which are, as I understand, undertake a wide range of data processing activities on behalf of the government.
Right.
And indeed, they still have, until I think recently, been undertaking some data processing for us. So they're an organisation like a range of other data processing organisations, and which they've contracted in. The IC took the decision that was a arrangement that was unacceptable. So the system was physically bought in-house.
Right. So are they the processing that they do? Are they now in the jurisdiction?
Northgate no longer process the data.
That's definitely.
They no longer do the data releases.
Okay.
The data release process is being bought in-house. That stopped in 2010. 10.
Or even earlier than that.
Maybe earlier than that. Yeah.
Okay. Can I just?
Quick question.
2009.
2009.
Yeah.
Just in terms of the Data Protection Act, are you satisfied that you're not in conflict with the Data Protection Act?
We are extraordinarily concerned about DPA. I had a 3-hour meeting with the Information Commissioner only on June the 11th. We're constantly concerned about this. We refer ourselves and others to the ICO regularly. We're in total consultation to them. At this process, we have a number of ongoing investigations, which we're not investigations, but a number of issues which we're looking at with the ICO. As far as I'm aware, we are not at any point in breach of the DPA.
Okay.
It's a matter of considerable, I can assure you, great concern for us.
Right, Charlotte, I think you wanted to come in next.
Quick questions. Just firstly, why weren't the expired licensees required to delete data before?
No, they have always been required to delete it.
But there hasn't been a sufficient audit function, one that I could identify that wanted to make sure that is now audited and absolutely happens, and that's part of the end-to-end process that we are putting in place.
And you are now completely satisfied that that process...
When it's in place, that is what will happen.
We've started the process of physically requiring. We're actually in the future going to require a physical certificate that you have deleted the data.
If I just clear that, what you said just isn't clear at all. You seem to say earlier you couldn't instruct under these agreements that were in existence, that you couldn't instruct deletions.
When the data agreement expires, at the end of the data agreement, there is a requirement that the recipient organisation deletes the data at the end of the data agreement.
And do you audit that?
We are absolutely going to audit now. And
not are you able to, but do you audit it?
We are starting the audit process.
So you haven't been audited?
No, absolutely not. And that's one of the failures of the past regime, absolutely.
So moving on, just very quickly, secondly, just to give us an idea, we understand that you're not able to require certain organisations to delete their data. Can you give us a rough estimate of how many patients' records are held by those organisations now who you have no control over in terms of requiring them to delete data?
To be clear, The control is that at the end of their legally binding agreement, they will delete the data.
I understand that, but the thing I'm asking is, you have just told the committee that, for example, SCORE and CAG, you're not able, you've written to them inviting them to delete their data.
To stop using the data.
They are completely legally entitled to give you the finger and put your letter in the shredder. How many patients' records do they and organisations like them currently hold who you are not able to currently require to delete the data legally, as you told the committee earlier?
I can't give you the exact
Could you possibly write to the committee with as accurate as possible number of patients whose data is held under those organisations who you specified you can invite to delete data but are not currently able to require to delete data at this point in time?
Just to reiterate, this is pseudonymised data, non-sensitive, it can't be identified, it'd be illegal to re-identify it. Secondly, we clearly could require them to delete the data if we found them in breach of the agreement. We have no evidence that they're in breach of the data agreement.
That's not what I was asking. I was simply asking whether you could give us a list, a number of how many patients' data are held under that situation, which you outlined very clearly earlier.
Absolutely.
Could you not repeat? Could I ask as a member of this committee that you don't repeat this point? One of your previous board members, Dr. Mark Davis, said in an interview and publicly, and it's reported, that there was a possibility of re-identifying patients. We all have seen enough examples whereby combining data means that patients can be identified. I gave you examples earlier of companies who claim that they can link patient care episodes across all the data they've got, and we know that spans a lot of years. It's not helpful, as the report wording isn't helpful, for you to keep reporting things. It's completely not identifiable. That's not true. And Dr. Mark Davis, when he was in post, said there is a possibility that data can be re-identified. We've had lots of examples, and it's been quoted in debates here, so let's not keep hearing that, because that's not helpful.
Can I answer that as a question? We absolutely recognise that there's a theoretical risk in some cases where there are sufficient sensitive data items in pseudonymised data for re-identification. That's why it's very strictly controlled. That's why our default position is not to give people pseudonymised data unless there is a clear and proper and appropriate purpose for it to do so. Secondly, to re-identify anybody...
Which could include insurance, which could include commercial, which could include whatever an end user wanted it to.
No, it will be subject to the advice from the Confidential Advisory Group. I am bound by the advice of the Confidential Advisory Group. If they advise us that it's inappropriate use, then we will not produce the data.
For future, but we're talking about past releases.
In the past, I am advised clear that it was a legitimate and a proper and appropriate use of the data for pseudo-anonymised data of this type. It's not being used for individual insurance purposes. It's not being used. In case of Milliman, for example, it's being used primarily to support NHS organisations actually manage their resources better.
You can say that, but I mean, I'll just go back to the point I made earlier, Chair, that the public don't like this.
Are you saying that, in fact, to use it for those purposes would be illegal anyway? Is that? And could I know Tim?
So just to clarify, on behalf of the government, of which I'm not a part, but just to clarify that the legislative intention of the CARE Act is to do two really important things. One is to require the Information Centre to ensure that there is independent scrutiny of all uses of person-level data, whether identifiable or pseudonymised, an extension of the existing role of the Confidential Advisory Group, and secondly, that the data can only be used for health and care benefits specifically. Now, there are regulations that will determine what those words mean will be laid before Parliament in the early autumn. But these are really important new safeguards, which I agree are not effective at this moment, but will be effective as soon as the Act is now effective, as soon as the regulations come in. But that was as a result. I'm sure we'll get onto it in a minute of the whole care.data conversation. But just to be clear, it would be illegal and subject to independent scrutiny for any insurance use, junk mail use. This data can only be used now for health and care benefit, and to ensure that's the case, there will be independent scrutiny.
So from when the Act
the Act is now in force.
Yes.
So we're in a period which is common legislation where we're between primary and secondary legislation. But I don't believe the Information Centre would for a minute authorise any uses now that were not consistent with with those requirements. And certainly,
But this is a complex question which we want the advice of CAG on. We're quite clear that we cannot and will not provide data for wholly commercial purposes. So for something which has no apparent benefit for health and social care, there's no question of providing the data. We cannot provide any data which allow for identification of individuals, for example, setting up premiums to insurance cases. But, for example, if we have a private nursing home or group that wishes to access the data so that it can review its benchmark, its services, then we will ask CAG's advice as to whether or not that is appropriate. And we will be bound by that advice. So this is a complex area.
Body which will
Okay.
So have SCORE set out what they want to use this data for, and are you confident they won't be using it for commercial gain?
They are a for-profit organisation, so in that sense that they are operating for commercial gain. They are using it for what we deem, historically at least, subject to future to CAG, for a legitimate purpose, which is to review the impact of a series of changes in of incidence of cancer and so forth, to look at the impact on reinsurance rates.
Right, so they are...
Are you saying the legislation was badly written then?
I couldn't possibly. I mean, we believe that the legislation was passed. We absolutely will live within it.
Do you think it was a superb piece of legislation?
I believe that's. I'm not in a position to. I'm not an expert on legislative processes.
Okay, an incompetent organisation is not able to judge another incompetent organisation.
Just a quick question. Where are you looking for the definition of health and social care? Is it a wide definition you're looking at? Or
yes, I mean, remember that
we
we are responsible for providing information and support to the whole of the health and social care system. And indeed, I'm very, very anxious indeed that, for example, in nursing homes and a whole series of other care settings, we're actually devoid of information. We have not sufficient information. So we believe that the provision of this information in those or some of those organisations would be vastly beneficial.
No,
but it will be subject to the confidential advisory group.
Right, I'm just asking about the definition. It's going to be used just solely for the purpose of health and social care.
Yes.
Who is making that definition? How
well,
do you work it? It's like a public interest test, isn't it?
Yeah, absolutely.
Depends on
my understanding is that regulations will be laid before the House in September, which will define that. There will be an opportunity, I assume, to debate it. And I'm very clear that CAG, which is a body of ethicists, clinicians, carers, social
professionals. So let's just go back. Regulations will be laid in September.
Yes.
Yeah. We are already working on the basis that the Care Act is in place. We're already in discussion with CAG as to how we can test this and seek their guidance. And even though the regulation is not there, we will not make any further data releases that we are not comfortable on would meet these requirements.
Approved use by a company that was a comparator website for the top private pay procedures. I've quoted that before. I think that was allowed in the last 12 months, but and given approval entirely to compare prices. So a bit like comparing insurance prices, comparing private pay procedure prices. That was one of your releases in the last 12 months. That's not a health benefit. That's a financial thing.
I would be very anxious that we get appropriate ethical advice on that.
Well, then that was one that was approved in the last year, I think.
Yeah, but because under the current arrangements, it's perfectly legitimate that they have that information. I mean, the whole point of the legislation is to strengthen the guidance, and as Tim has made clear, is to strengthen the position. And we are very, very supportive of that. And we believe that's a very substantial step forward. It is inappropriate for us to be making what are essentially ethical, in principle decisions. It's appropriate that an external body should do that.
Can I, before we move on to the next group of questions, can I just ask one technical issue that's been raised with me, and that's around the sample testing methodology. Sorry, I'll speak up. Yeah. Around the sample testing methodology. That if I turn to Appendix 6 of the report, the haphazard selection and a sampling method that takes in about 10%. Do you feel that that was appropriate? Do you think there's a danger you could have missed out some important cases? Do you feel it would have been better to have taken a more risk-based approach where you're targeting on higher risk cases?
I believe it was the appropriate methodology. It is one that is appropriate for looking at managerial and process issues. It's a standard practice within audit companies like PwC. I think it would have been inappropriate to use a more clinical research kind of process to drive this. And I think the the proof of that particular pudding, goes back to the research issue and the ONS issue, because one was identified in that, and that sparked a straightforward, let's look at all of the others that are in that same grouping, yes, and identify what is there. So I think that 10%, 1 in 10 sampling is robust enough to have identified both the key issues, which the report has done, and to have thrown a spotlight on anything that required further investigation. It was appropriate for the kind of audit that it is.
Right, so you're satisfied that a high-risk grouping couldn't have been missed with this approach?
Yes.
Right, thank you. Right, I know we're about to have an imminent vote, but I'm also keen that we sort of move on now from the PricewaterhouseCoopers report. But thank you very much, Sir Nick, for your comments on that. And I'm going to come on to David Tredinnick.
Thanks. I'm going to ask some questions about the current position on care data, but I just say I think what I certainly want to do, and I think most members of the committee want to do, is to make sure that the most data that we can put out there safely for improving healthcare in this country, the most we can get hold of and put out there to the public safely is really what we want. We want to try and get this information out there, but it's because of the dissemination of data now, it's so easy. And we heard in an earlier session how there's some data out there up in the cloud, up on the black web even, I don't know, which has been put up there for commercial gain. Nobody knows where it's come from, where it's going. It only takes one slip, and this is gone forever. It's out there. I mean, we live in this. So that's why there's this forensic questioning, I think. I think we're deeply worried about this. And I want to know what has been happening since the delay in implementation of care data was announced in February, please. What's happening on that, Mr. Kelsey?
Shall I try and answer that? So essentially, I think everything I've heard from the committee is right in relation to the importance of ensuring that we do everything necessary to build trust in data sharing, and in particular the linkage of data and general practice to that in hospitals. So since we postponed the programme in February in response to, I think, very legitimate concerns about the apparent absence of safeguards borne out in Nick's report for the users of data, which I think the Care Act has done a lot to provide a new basis for, though there are other things we need to do as well, which I'll come to in a second. And also a lot of concern amongst GPs and patients and public about the relevance, the information that was provided to people to maximise really their knowledge of the new right they have to object to data being shared, which we haven't talked about, but is a really important additional safeguard.
What I'm wondering is, sorry to interrupt you, Mr. Kelsey, but there's been a division, and perhaps it might be nice when we come back, having set out what the problem is, to focus on where we are. That would be great. I'm very sorry for another interruption. apologise again for the interruption, and as David is back, I think it's best we crack on to just to remind the number of the questions, what's been happening since the delay in implementation of care.data was announced in February. If you could update us perhaps, Mr. Kelsey, that would be really helpful.
So if the committee remembers back, there were a number of reasons why the decision to delay was made, and the first of those was widespread concern in the media and elsewhere about safeguards of uses of data, and it became very self-evident that without some very serious focus on that issue, public trust was at risk. So, and we've talked a little bit about the Care Act provisions, and that's part, I think, of the way in which we can start to build trust in data sharing in general, and this particular programme specifically. Alongside that, there were also a number of concerns raised by GPs and by members of the public and their advocate groups around the degree to which the public information provided, different ways in which people were being informed of a relatively new right to be able to object to their data being shared, was being communicated. And for those reasons, we took the decision to postpone the launch of the programme. And since then, we've been listening. And I'm not afraid to say that we're learning a lot about how a modern public service does need to operate in relation to this incredibly important conversation with people about the way in which it wants to suggest their data is used. So we've had about 120 events around the country since February. We've engaged with nearly 3,000 different people right across the community, from civil liberties activists through to patient groups, through to individual citizens. And what we are hearing is a consistent series of concerns about that we need to address, and I'll come to what we're doing in a second in addressing those. We've also listened by virtue of bringing together something called the Care.Data Advisory Group, which is chaired by Kieran Devane, the Chief Executive of Macmillan Cancer Relief, and also a non-executive director of NHS England. A number of people behind me are on that group, but it brings together the BMA, the RSGP, Health Watch, and civil liberties groups, other patient groups, and so on, into a constructive challenge to NHS England in rethinking how we are going to build trust in this programme. In addition to that, I personally have had numerous meetings with BMA, RSGP, and others, Health Watch again, to ensure that we are, the research community at large, to kind of start building a basis from which we can start to move. So the essential position we're now in is that, having and continuing to listen, we are now proposing a phased rollout for the programme in the autumn. So you'll remember that we talked about a 6-month delay. What's now being proposed is that indeed it will restart with a series of pathfinder practices, no more than 500, in the autumn period, and that phased rollout will investigate how best we can set a new standard, really, for patient and public information in relation to this vital conversation. As you were saying earlier, the objective we all share is to ensure that data does flow to secure patient benefit as quickly as possible, but it needs to be done right in a way that where patients, public and GPs, are all able to fulfil their functions and understand their rights properly. So we will be running a series of pilots, if you like, pathfinders we call them, in the autumn to investigate how best that can be achieved. That pathfinder phase will be subject to transparent and independent evaluation. So we have a number of people who we've asked to provide us with advice in reflecting on whether enough has been done at that point, or whether more needs to be done in relation to communicating the opt-out and other new positions. And Fiona Caldicott's independent information governance and oversight group, for example, has agreed to work with us on assuring the process around the monitoring of those pathfinders and the construction of the phase. So that's one really important lesson we've learned, which is we want to work together with GPs, with patient groups, with local citizens, communities at Health Watch and others to come up with a schema that will deliver properly trust-based, properly informed steps for moving forwards. Alongside that, there are a number of other shifts, changes that we're proposing, one of which, as Kingsley mentioned earlier, is that when people access this data alongside the provisions of the Act, they will be encouraged, in some cases mandated to do so inside the safe environment of the information centre, where an organisation is of such capability that it can be confident it will manage and is subject to various audit processes, manage this data safely. It will be at risk under the new legislation of one strike and you're out. There will be significant downsides for people to operate outside the safe environment of the information centre and handling the data. So this data laboratory, this sealed environment is a really important part of the new proposals. And in addition to that, we have also committed to ensuring that the scope of the programme, I know of particular concern to you, and has been raised, as Nick said earlier, with me and with the team by a number of parties, defined originally in conversation, or not the conversation, in direct negotiation with the BMA and the RSGP, was specifically designed to be of specific benefit to local commissioners. And for reasons that are related to that, though I have got to say slightly opaque, certain classes of code were not included in the original scope, and those included musculoskeletal codes, and they also included what are called sensitive codes. So we will be publishing a roadmap for how we will be offering people the chance to make a case for inclusion of new codes of data within the extraction before we go to the Pathfinder stage. We will share with the committee, obviously, details of that, because I know it is a really important part of the programme moving forwards. So in essence, there are many other detailed changes that we are making to the programme, but broadly put, a combination, we hope, of legislative and other safeguards so that there can be complete transparency and no doubt at all that data that is linked, that is provided by people to this programme, that the uses of that data are completely transparent, and that, on the other hand, they themselves are entirely aware of their right to object and for that objection to be upheld in the event they don't want their data to be shared.
So to clarify, that there will be independent scrutiny
Yes.
of those pilot sites.
Yes.
And did I hear you right saying that that will be under the auspices of Fiona Caldecott?
So Fiona chairs
it.
the Independent Information Governance and Oversight Group, and it will be that group that group chaired by Fiona will be one of the parties that will express an opinion about the degree to which and help us assure the process for those pathfinders. Other leading voices, including Sally Davis, CMO, and others, will also express a view. The caredata advisory group will express a view, and the decision finally will be made by the programme board of caredata, of which I'm the senior responsible owner, but also in the context of the boards of NHS England and the Information Centre as joint data controllers being in agreement. So there are a number of key voices that will need to be in agreement that we have achieved a suitable standard of public information and confidence before we move ahead.
Thank you.
Your background,
my personal background,
is I've got it. We all have your CVs, but I mean, you were Executive Director of Transparency and Open Data at the Cabinet Office.
Yeah.
And you've got a huge experience and have won awards for your innovative thinking. Is there anything out there in these new proposals that concerns you, given this huge range of experience?
Yeah, I mean, I am concerned about the fact that I think we're in a very different. The benefits case for this, I think, is really strong. We have real continuing examples of poor cancer survival rates, late diagnosis of illness in a way which we know is harming people. There are people dying because we are not linking data in a way that will help us support general practice and local services to deliver earlier diagnosis of conditions. That on the one hand. And on the other, we are in a 21st century environment where nothing is safe, data-wise, really. I mean, we've got to be absolutely upfront about that. And we need to have a different kind of conversation with people about the trade-offs that we want them to be part of making with us, which is, on the one hand, how do we service this extraordinarily important human benefit, but on the other, give them the right to have a proper say in how their own data is shared. And to be honest, this is new territory for not just healthcare, but for the public service in general. So I think this will be a conversation that we're going to have to learn a lot about. I think it'll take time for us to really make it happen in a way that is credible to some of those external authorities. I think it's a really big shame that this hasn't already happened. I think it's a very long overdue conversation. So I think there are some big challenges there, but all I can do is try and reassure the committee that in every single way I can think of, I'm trying to make this a problem that is owned not just by some grey bureaucrat in a public service, but by the community at large of people who care about the future of the health service, so Health Watch, local charities, the various GP leadership wasn't, across the board.
Can I maybe raise one issue with you? It's quite topical this week, and ask you whether you feel, Mr. Kelsey, it could be a risk. The Secretary of State has raised the possibility of red flagging GPs, for example, sort of naming and shaming, I think is the term he used. Do you think that undermines the confidence that GPs would have in actually being involved in these pilot sites and wanting to share their data if they see it's going to be used in a sort of naming and shaming kind of context, rather than the context that perhaps was envisaged, that it should be about allowing us to identify outliers and actually help them to improve their practice? I mean, do you think this sort of naming and shaming issue is one that is a threat to participation in care.data?
Well, I think the Secretary of State the government has announced, Secretary of State has announced a series of plans to promote transparency of healthcare, and I applaud transparency. I've long argued for it. I think the point you're making is it needs to be fair. The data and I have to be absolutely clear, I'm not entirely sure which data set was being referred to in the comments the Secretary of State made, but for certain I support the push to fair and open transparency of outcomes in healthcare. Care.data, in terms of linking, at this stage at least, general practice data with hospital data, does enable a much more sensible and real conversation about the relative performance of different parts of the system. I think it's a really complex issue. So I think in understanding, as it were, the relative responsibility for, say, an avoidable death because of a late referral for cancer.
Indeed, I think we're all agreed that identifying variation is important, but the question I asked was whether you see that particular issue of sort of naming and shaming and red flagging is one that could set back, because as you will know, there were very serious concerns raised by the BMA and GPs about the original rollout, and that's why one of the reasons it was set back. Do you think this particular announcement is likely to be again a barrier to participation?
To be absolutely honest, I spoke to the BMA this morning. I haven't picked that up as an issue. I don't think they're associating the legitimate public interest in understanding whether a local community is being served well or badly by a general practitioner or by a local health service, with data that's fair. Over there, I'm not picking up that those announcements at this stage are impacting on people's views around care.data. And in fact, just to be clear, I was at a meeting yesterday of the Nuffield Trust where a number of GPs, and both in their provider and their commissioner, wearing their commissioner hats, were talking with enormous frustration about the degree to which the absence of these linked files, these linked data, safely shared, is contributing to their own inability to do some really important local things. But I'm not picking up people going, over here the government's current push to transparency is somehow contaminating their interest in care.data actually happening in a safe way.
Yes, please.
Just GP pilots.
Yeah.
Will patients be written to? Will they be required to opt in, or are you still operating the opt-out system? And at our last meeting, when we discussed the form that people would have to fill in to opt out, I think we generally agreed it was quite aggressive and threatening. And have you changed that form?
Yeah, so the opt-out and the way it's presented to people, and bearing in mind that this isn't just a one-size-fits-all solution either, there's a whole accessibility issue, has been worked through in enormous detail. So I can reassure the committee that the way in which the discussion is had will be much more personalised to the person with whom that conversation is being had. And we'll evaluate that, just in terms of the opt-out. But in terms of the plan does remain that this will be an opt-out based scheme. And the reason for that, I hope the committee will be aware, is because disease burden, as you would, I think, told by Peter Weisberg at the last hearing, that the disease burden we're aware of is with the most disadvantaged on the whole. The NHS has a fundamental obligation to serve the entire community, and for that reason, in order to plan services most effectively for need, we need to have as much data as possible. So the opt-out is the proposal remaining that NHS England is proposing. In terms of ways in which that opt-out will be properly informed to people, certainly various people have raised with me the idea that a letter to patients could and may be an important part of raising awareness of their rights. So in the pilot Pathfinder phasing, we will certainly be investigating whether or not that is a good tactic to make sure people are properly informed.
Okay, can we go to simple sentences which involve what does personalisation, as you've just said it, mean? And the question was, has the form been changed?
Yes,
or
it has.
not?
Yeah. The form is being changed.
No, has been changed or is being changed? Which? This is why I can't listen to you guys. The language is waffly. You don't say, it's all woolly. We're all over the shop. It's either been changed or it hasn't been changed. Which?
Can I just say, I think there may be a slight cross purposes here, because you quite rightly, you and Miss Keeley had quite a go at us about the opt-out form that we have on our website. I think you're referring to that.
Oh, that's what you're referring to, sorry.
And we took that criticism away, which was extremely fair criticism, and
that.
indeed we consulted with the ICO, and a new opt-out form, a much simpler one, much more straightforward one, is on our website today.
It's on your... So if I go there today...
Yeah.
We looked at it earlier. I hope you'll find it. It's there.
Sorry, what I was referring to was in the context of these pilots, we actually want to work with GPs and with patient organisations locally to develop materials that will deliver to somebody with learning difficulties or somebody with other conditions a means of understanding what this is all about.
Could you now tell me what that personalisation, how would you do that? I mean...
Well, an example was we had my colleagues had a meeting with MenCap this week actually to talk about materials appropriate for people with mental health difficulties in relation to explaining what an opt-out is, visual aids, all sorts of things of that sort. So one of the criticisms that was made at the time we paused or delayed care.data was that we had not done enough work on accessibility of the information to the wider constituents of the community. So that's what I mean by that.
Okay, my father, he's been asked if he would contribute to a cancer research, and he would want to, but I've written on it, no, he won't be. If you guys are involved, I won't have anything to do with it.
Can I just ask, Valerie, do you feel that your question's been... Oh, right, yes. Probably has been answered, so we'll go on to yours.
So just more questions about opt-out, because really I think this question of respecting patient objections is one of the keys to moving forward with the pilot. I have to say I rather resent you saying I had a go at you about the consent form.
You're quite right.
Just to understand...
You made some very useful and helpful points, and
okay,
I'm very grateful for that.
Well, that's a rather disparaging term, and it'd be better if you didn't use it.
I was at the end of it.
Fine, okay. Well, you know, I think you are in the role of an organisation that's really caused a lot of mess, a lot of pain, a lot of difficulty for people. I mean, I gave an example earlier of somebody who objected and has come out of the NHS. I also gave examples of somebody who wrote to me and said he wasn't as frank with his doctor as he might have been in a consultation because he was so worried about care.data. You know, we've given examples where researchers in university are mining GP records, and you know, there's all kinds of things. So that there was a carelessness that it would, you know, as we keep saying, it would be helpful to understand. So you've touched on what progress you're making on that process, but I think this I think is the issue that you need to be more careful about. I was concerned in what you said about challenge, that you had appointed somebody from the research community that's going to most benefit. You said somebody from Macmillan Cancer Care was chairing the group on challenge. Do you not think that challenge needs to come from people who are not the most placed to benefit from moving forward with care.data?
Yeah, so sorry, the care.data advisory group, I'll send around a note of the membership, includes Big Brother Watch, Med Confidential, Macmillan chairs it. They're a charity. They're not just a research body. They also provide health services. Includes the current president of the Royal College of Psychiatrists, because there's a big issue about mental health data in relation to the extraction.
Yes, fine. But you said it was chaired by somebody from Macmillan Cancer Care.
Yeah.
If you're going to put at the heart of stakeholding, or you said a challenge group, you've put somebody there who's from an organisation that's most going to benefit, because I think we'd all understand the cancer organisations, the cancer research organisations and the research organisations in universities most want to benefit from this. They want more data, as you yourself. I mean, one point that we could go back to, because David made the point about your own background, you were actually working, I think, for Dr. Foster when the NHS Information Centre struck a deal on releases of data. So your background, I understand you're an enthusiast yourself, and I just think there's a difficulty in handling this moving forward on care.data with people like yourselves that are such enthusiasts. You know, you and I exchanged social media comments about quotes about open data. If everybody involved with challenge, with taking this forward, with caution, is actually such an enthusiast as you are, I mean, do you not think in some ways you weren't making much of a contribution earlier? It was Sir Nick Partridge that was answering most of the questions. Does not your own background actually makes it difficult for you to be in charge of a culture change that we've talked about? Because you're the enthusiast, you're the person that wants to go ahead at a pace. You know, I've seen articles and presentations from people who work on this. They're all enthusiastic for moving this forward. What we need to hear about is the caution and the slow steps that will restore confidence. And it's just an interesting question for you.
No, I think that's look. I don't think I've ever faced as much challenge personally as I've faced over the last 6 months. It's been a very important reflection from people who are not, including members of this committee, who are not in any way do not share my worldview at all, may not support transparency. I think people do, on the whole, seem to support use of data to drive improvements in healthcare, but not universally. My response to that, and not just mine, but the response of NHS England, the response of the community of people who care about an informed health service, as it were, is to in this particular programme to offer the reassurance of total transparency. So the phased rollouts, it's not me doing it, it'll be a group of GPs, as I say, up to about 500, from whom you will be able to hear directly. You know, were they able to discharge their responsibilities? Do patients in those practices feel that they understood what their rights were? I think it's a fair point. I think that I am an enthusiast, but I also think that we are learning to listen in a way that I think will provide a solid basis for this kind of project moving forwards.
And was there independent scrutiny of the selection of those pilots?
Sorry, I couldn't quite hear that.
Was there independent scrutiny of the selection of those pilots, as Dame Fiona suggested? You said that she'd be involved in monitoring.
Yeah, so she's, well, not just monitoring, in the process for also the selection. So yes, there will be a variety of independent inputs into the way in which those practices are selected, and obviously we have been working with all the people you'd expect, the GP bodies as well, to figure that out so that they will be properly representative. And one of the commitments that we've made is to try as hard as we can to make sure that within those participating practices are those that are very sceptical, cynical, critical even of the programme.
If we want to move on to it, there's a further question about the use of data rooms for researchers, keeping the data. This was a safeguard. We've talked about various safeguards, keeping the data or some types of it at the information centre and requiring researchers to go into that room. Perhaps you can tell us anything that you've learned from that experiment and whether researchers have been happy with doing things that way, because these safeguards are very, very important.
They are very important. So I referenced this a little bit earlier. So one of the preconditions, in fact, for the initial extractions, even from the pilot sites, will be the publication by the Information Centre of its proposals for sealed environment facilities, for which most users of this data will be either mandated or strongly encouraged to use them, subject to CAG oversight. There may be bodies who are given the ability to handle the data externally, but that will be subject to independent scrutiny. So it will be a precondition of us beginning even the extractions for the Pathfinder phase that those proposals are published.
Valerie wanted to come in and then Charles.
Just a follow-up of that, could you say when the pilots are due to be over?
To be over?
Yeah.
Well, at the moment, there are a number of preconditions that need to be met before they can even start. So one of them is clarity around the regulations we talked about in relation to sort of completely being clear that commercial insurance will not be permitted in uses of this data, and a variety of other components relevant to the CARE Act. There are some other preconditions, one of which is that the Information Centre has published its Code of Practice, which is a statutory requirement currently out to consultation, that it has published its proposals for the sealed environment that will be offered to people with appropriate authority to look at the data, and so on. And indeed, of course, that the GP practice participating and their patient representative groups have agreed the materials and the style of the programme is appropriate in their view. Plus also, we will have conducted independent research, which has now finally been commissioned after, to ensure that not only do we have a baseline in relation to public perception, both nationally and within those those pilot areas, but that we can monitor a degree to which there is indeed some view that at least the materials, people's sense of being invited to make a decision has been made real. So there will be, all those things are required before we can even start. So my view right now is that we will, all being well, be looking at an initiation of the first extractions during the course of late October, early November. But there are no artificial deadlines here. It is too important that we get this right. So if, in fact, we feel uncomfortable at that point, we will just give ourselves more time.
And so we're talking about, in your estimation, say you start on your time frame, do you think it'll go to the other side of May 2015? Or?
In terms of the national rollout?
Well, no, the pilots.
Well, no, I think the pilots...
The pilots...
Yeah, so the actual extraction is a 2-second process, as it were. The data being removed from the software systems of GP practices. So the important bit is that obviously patients, the GPs, have been able to have the conversation.
I know that, but you have to assess it, don't you? You have to
assess so the evaluation...
You don't have a pilot unless you want to assess the
results. No, so yes, there'll be a period during which the evaluation will be considered and recommendations made. Right. I don't know how, maybe a month, that would... we can, after the extractions have been determined, so that probably takes us into the early part of next year. There will then be a lot of consideration, and whether we move to a further set of pilots or beyond that will have to be decided at that time. So I can't give you a deadline, a time for when it happens.
Okay. So we're really talking about sort of, middle of 2015.
It depends.
Okay. I just wanted one other question. What have you built within the system that patients can find out where their identifiable data has gone?
So,
is there any way a patient could find out where their
Yeah, so I think this relates to the point that actually I was just discussing with Sam from Confidential Outside, which is relates to, we want people to know how their data sharing benefited other people. It's a really important thing that people can be aware if they take the decision to participate, that they can see how their data was used to and to what benefit. So one of the things the Information Centre has committed to, and indeed will also be a precondition for the launch of the Pathfinders, is that there is a process of complete transparency about uses to which this data is put, as we've just discussed, in terms of individual organisations and the uses to which the data is put. There is a is that what you're... So people will be able to track, to some degree, the way in which their data has benefited? Is that what you're...
Joe and Josephine Public is their data. Is there anything in the system where a person can actually know where their data has gone and for what purpose? It's a very simple, straightforward question, isn't it?
Well, I mean, the data will flow into the Information Centre if people don't opt out for the benefits.
So they're not going to know, is what you're saying?
Well, the Information Centre will then publish.
In that case, you're not as enthusiastic for transparency as you thought you were.
Can I? I think this is a very important question. Yes, can I address it? You talked in terms of confidential data. If it is identifiable, the only likely reason we would ever supply it to a third party, whoever they were, would be under Section 251, colloquially. Under that, there's a requirement under that in fact we only agree with those if in fact they cannot get individual consent. Notice of those have to be posted, and indeed individuals have to be given an opportunity to object to it. I think that we need to be that process. At the moment you have to go to the HRA website and all very complicated. In our process we will increasingly make that available directly on our site so that you will be able to see that these studies apply. Right? And one of the things we're looking at is to put together an index system so that in fact you would be able to ask us in future, where was my confidential data passed to, which studies would it go to? And I think that's an absolutely appropriate thing to do. Pseudo-anonymization data is more difficult because once it leaves us, it is essentially, it's de-identified.
Yeah. So it's not.
Sorry, it's the identified data. So that is more difficult. One of the things we are requiring under the data service contract we're going to have is statements of benefits associated with it. So if you come to us and say you want this data for this purpose, we're expecting you to come back, and you're required to come back and say, actually we did it, and this is the benefit of it, and this is the public benefit of it. So we want to see a benefit case for it. But traceability, I think, is an entirely reasonable expectation. It's up to us to find technical ways of doing that.
Can I just ask you to confirm? I touched on earlier, but we've talked about in greater depth earlier, in earlier meetings here, that we were told, I think by Dr. Hisley Cox, that there was mining by undergraduates or graduates, people at universities, of NHS GP records, that there were pilots to do that, and that was done without sort of any consent issues being, they didn't have that support, and I've raised it a couple of times. Can you assure us that there's nothing of that sort going on anymore? Because I've sought assurances and not got them in the past. I think you've just said, you've been very clear about
we
what
don't
patients
at the moment. We don't have any access to GP records other than purposes for things like QOF and immunisation records and the rest of it.
So who would know if it's not yourselves? Who would know?
One of the things we have been commissioned by the Secretary of State for is to take a much broader responsibility with regard to data security across the system as a whole. Because I share your concern that we hear equally colloquial stories about this being done, that being done.
It wasn't a colloquial story, it was given to us in evidence.
If we had evidence, where we have hard evidence, clearly this would be illegal. It would be, we would alert the ICO immediately. We would take action against any organisation that where they were misusing any data.
Julie has examples. She needs to report them to the ICO.
No, absolutely. We are absolutely. I say the same time. If anybody has any evidence of this, then we want to know, and so does the ICO. Yeah. I think we are generally concerned, to be blunt, about the level of data security across the system in the light of the improvements of technology, the increased risk from state and state-sponsored terrorist organisations and organised crime. So
I'll send you the information I was given, but I'm raising that because we were given that information.
Well, we are absolutely wish, and one of the things we are encouraging within our own organisation, and we wish across the system as well, is the notion that individuals should tell us about data breaches. We want more data breaches reported. We want to know what goes on in the system, because that's the only way we're going to get it better.
Well, to be clear, individuals aren't going to know that their records are being mined.
No, I mean,
the research community.
If somebody has knows of cases where this has happened, then they absolutely have in my view, a public duty to tell us.
Okay. Duty for you not to allow it to happen. So if you lose a few bits of data, a hospital or loses a laptop or a hard drive, there's mayhem. You could just lose 50 million out there and then it's okay.
No, we haven't lost.
You've just given it away?
No, we haven't. It's under strict regime.
Basically,
in fact,
Charlotte was coming in next, and I think we've dealt with the PricewaterhouseCoopers issue previously. Thank you, Charlotte.
It's just, I'm afraid I'm going to take you back just to a question I asked much earlier, because there's been sort of lack of clarity, and I've been asking, it's much easier to get the clarity out now than write you letters later. And it's regarding the youth, what about youth study. And I just value some clarity on it for public record, really. It didn't receive Section 251 support. But on the website, it says, we have received approval to use your contact details only for this study. Your contact details were taken from the NHS registration data held by the Health and Social Care Information Centre and the Department for Education's National Pupil Database, which contains details of every pupil in England. The NHS registration data has been used as a reliable source, etc., etc. So it does say we've received approval for this study. Now, what people are asking is, if it hasn't received Section 251 approval, has it received approval? And could you clarify that? Because it appears to the layman to be contradictory to what you told us earlier.
I'm sorry, I was given notice of this half an hour before I came this afternoon. I'm not going to comment any further than I did earlier, because to do so would be improper. I've given you what I'm aware of. I'm sorry, I can't go beyond that at this point.
So perhaps you'll like to...
Yeah, absolutely.
If you could, right,
put down a parliamentary question, totally legitimate. I was alerted to it this morning we will give you a complete
I understand
answer
that,
to that.
but yes, and you understand from the committee's, our job in the committee is to raise concerns on behalf of the public, that it does appear to be contradictory.
But I'm sorry, I'm the non-executive director of an organisation of 2,200 people. I was given half an hour's notice of this question. I will ensure that you get the detailed response you require.
That'd be very kind, thank you.
I found the reference to the information that we were given as a committee. I mentioned it in debate. I mentioned it in debate here in the House. Professor Hibbersley Cox and Professor Ross Anderson pointed out to us, in evidence to us, that researchers already made use of free text from GP patient records. Medical students and computer science postgraduates at the University of Sussex and Brighton and Sussex Medical School have begun analysing doctors' notes taken from free text. And that was done without Section 251 support. And that's the evidence that was given to us. So the reason I've raised it a number of times is because it's concerned.
We extract no free text from GP systems.
Understand that, but
I'm alarmed by what you said.
You've pointed out that you should be in control of that, and I think you should.
And on that point about free text, can I ask Mr. Kelsey if you'd like to put on record whether you have any plans to extract free text in the future, because it's in free text that people often record their most personal data, and I think that is something the public would feel concerned about if they felt there was intention to extract free text.
Yeah, no, there's no current intention, nor is it in scope for caredata to extract free text from GP systems. As I said, we're going to have a process which we will publish in advance of the Pathfinders to make sure that other omissions or like musculoskeletal are included, but we're not planning to include free text.
Right.
And that to me is why I added as an appendix to my report what a HES data extract looks like.
Yes. Right. Thank you. I'd want to come on next to the issue of pseudonymisation, if that's all right.
Yes, I'm sorry I had to leave the room for various reasons. Another concern has been that the data collected from GP records will contain specific identifiable information about patients which will then be anonymised by HSCIC. Has any progress been made on pseudonymising data at the point of collection? I think I've just about pronounced that correct.
Yes. I'm going to hand over to Kingsley to answer that.
Thank you. As we discussed, we've set up a working group on the potential opportunities for pseudonymisation at source. That work is going on. They're incredibly diverse. This is a debate and discussion which raises enormous technical challenges, but also technical emotional debate about it. We are open-minded on this. We have an interim report which we publish before the end of the year. It is one of the routes of development that we're very keen to explore to see about the viability of it. So that work is ongoing. I'm very happy to come back and report on it when we reach the stage where we have a conclusion.
Because it's the theoretical possibility, even though it would be illegal, of people being able to track data back to individuals that seems to be at the heart of this. And so that is something that, as a group, you recognise.
And the problem is that linkage requires some degree of identification.
Yeah.
So we're in this tremendously difficult bind between the fact that if we eliminate any risk of re-identification, we can't link the data. So even if we pseudonymised at source, we would still have to have some way in which we could link the data. The link the data would require us to have some process of putting identifiers into the linked data. But
you'd be linking it with a hospital record, not necessarily back to an indivial where somebody could identify it as an individual.
We'd have to know which hospital record went with which GP record. It is a very tricky little problem, one which we are we're spending a lot of time and effort.
So you're actually actively looking at that, and you're
pseudonymisation source. As I said, we have a working party on it, which is populated by a whole range of external experts. This is not an internal one to us, and we're taking the best available advice we can.
Yeah, you are. I mean, but we at our meeting on the 8th of April, Max Jones said HSCIC was undertaking a review of all available pseudonymisation techniques. I think that's going to be put to a steering group. Have any conclusions been drawn?
No, as I said, there will be an interim outcomes will be available, I think, before Christmas.
So is it? I don't know whether Mr. Helms, through you, Chair, would like to comment on that, because you.
Yeah. So there are some. I'm not the technical expert, but there are some at the moment. Unfortunately, the NHS at large is in a position where it's not. comprehensively adopted safe digital record keeping. In our primary care, in our general practice facilities, we have probably the world's most advanced digital infrastructure, because the taxpayers invested over a decade in building that. In our hospitals, we do not have. We still have widespread paper record keeping, and as a result of which, pseudonymisation at source depends in part, at least, on people using similar systems for their data handling. So it'll be quite a long period of time, even if we were to adopt that strategy, which I have to say I find very attractive, before we can simply build it in a way that will enable data linkage to deliver the benefits we've just described. So pseudonymisation, to which this programme is fundamentally committed, whether it's in the information centre or at the GP source, needs to be as safe as is possible. But the opt-out exists for people who are persuaded, who's still not persuaded that it's as safe as it can be. But the Information Centre is conducting the review and doing so with a whole range of experts, including Julia on the team.
Tim makes a very good point, which is that actually the pseudonymisation source might be most feasible within the GP system, but frankly some of the hospital systems technically can't do it. So we have to think about the ways in which we do this across the system as a whole.
So it's enormously technically challenging, but you're looking at...
To enable linkage.
Right. Yeah. Thank you. Could I ask a general question? I know, Mr. Kelsey, you've talked about people owning their records and being able to share them with who they like.
Yeah.
And that's a fundamental importance. We've been talking about a long-term conditions report that's coming out tomorrow. So recognise the benefits of patients controlling their records and sharing them. Given that fundamental principle that you own your own records, does that... I think that goes to the heart of people then saying, well, in that case, why don't I have the ability to opt in rather than opt out? And I can completely see you've set out the benefits of opting out, but is there a conflict between those two principles?
Well, the evidence is really clear that the people who need health services most receive them least, and that they are also least likely to opt in the way that if we were to offer that service. So if we want an inclusive national health service, we have to be able to plan in the interest of the entire community, particularly, I think, those who would be least likely to opt in that scheme, in a scheme of care.data. But that's a public debate. We can have it. People take a different position. Meanwhile, it's absolutely fundamental that we give people the right to not just access their own data, but do as they wish with it. So in parallel to the care.data programme, NHS England is committed to providing citizens with access to GP records on their own terms, if they wish it, online, from March 2015. Indeed, in the current GP contract, that requirement exists and has been accepted by into the contract. So this year, GPs are required to provide that service. And next year, we will, in agreement with the BMA, we will be enhancing the amount of data that flows should people want to receive that online. So I share with you a fundamental view that this is people's data, that they should be able to gain access to it and do for a whole range of different benefits. At this point, given where we are digitally, in a future world, we can imagine that at that point, people would be able to express a preference for how that data might be used by third parties. But where we are now, we're in a situation for secondary uses of the sort that care.data represents, i.e. for the broader benefits of us as a society. The only viable answer, if you wanted to have a long-term sustainable health service, is for an opt-out system to exist, in my view.
Right. And so just further to that point about how people opt out, do you envisage a system where people could state their preferences? If they do decide to opt out, they could say which bits of the system they want to opt out of and which bits they'd be happy to opt into, and making that more specific, or would they be opting out of everything?
So Ben Goldacre, who's on the care.data advisory group, amongst others, has been amongst those voices calling for exactly that kind of preference. Again, at the moment, technically, first of all, we're listening. So the first thing to say is we are listening, and actually we want to find ways in which we can do as much as possible to alleviate the concerns people have got about the a poor opt-out. What we want is a good opt-out. In other words, an opt-out that's properly supported with information, so people are making a proper decision, and an opt-out that, as far as possible, gives people a chance to express their preferences. We do have some logistical and technical issues, but absolutely, work with Ben and others to figure out what the roadmap might be to a point where we can offer that kind of...
Because is it so technically difficult to say, I'd like to opt my data into bona fide medical research, but not for other purposes? Is that...
Yeah, it's been raised, and we are. I mean, it's been raised, and we are listening to it. There are some technical complications.
Yes.
But we have put in place a piece of work under Professor Martin Severs, to look at the issue of consent and objection across the system as a whole. Because as I commented last time, at the moment it's incredibly confusing, and it's not consistent across the totality. One of the things we're looking at is this concept of dynamic consent, contextual consent, i.e. the notion that you would be able to specifically... Technically it's challenging, and it is difficult. It also raises some very interesting questions about the security of the data once you pass it to third parties.
Yes, exactly. So you can't, once it's gone, it's gone. So you couldn't retrospectively...
Well, the difficulty is if I download the data to my diabetes diary, for example, and then I go and visit my GP, how do I reintegrate that data back into the GP system, for example? And then about the usage again, I may change my mind. So it's technically challenging, but the government in its regulation document, in its consultation document it published last Wednesday, made a commitment to moving to a system based to a greater extent on consent in the future. That is a position which we very much support. And I think the challenge for us is to find ways which are technically feasible and are not unnecessarily expensive.
And is that going to be part of the pilot? So you'll be comparing different ways?
It's not feasible in the short term.
It's not feasible in the short term.
It's not feasible.
Thank you. Rose, going to come in.
Mr. Kelsey, you just said, we were talking about the opt-in, opt-out, and you said that the people who are most in need of health services would be the people who would be most unlikely to opt in. So if I take those thoughts to its logical conclusion, if they're less likely to opt in, they're also less likely to express their preferences. So they're just going to get what they're given, aren't they?
Well, that's why we need to work really hard on creating a good opt-out. So the challenge we are in is that what Victor Adebayo describes as the inverse care law is a reality, and we have to find ways in which we can communicate with all our society, but particularly those the most disadvantaged, to make sure that they are not in the position you've just described, so they are as fully aware of their rights to object as anybody else is. It's a significant challenge, but we've just got to find a way to address it, which is why the caredata pilots are being phased, so that we can be transparent and properly understand how best to achieve that. But I honestly don't think that so far any public service has cracked the problem of inclusion on the scale that we're currently talking about here. This is not a small undertaking.
No, but no public service has actually taken all our medical records and thrown them in the ether either.
So a very, very specific point that's been raised with me is what data fields would still be extracted even if people opt out? It's just a query that someone set. Yeah,
so there'll be, in fact, for clarity, can I just read this out so that we're absolutely clear it's on the record? Once your objection is recorded, no information about you will leave your general practice other than in exceptional circumstances, e.g. court order or disease outbreak, under Section 251. However, the HSCIC may hold data about you from other parts of the NHS, e.g. your local hospital, so your GP will send a message to the HSCIC to ensure that it also implements your wishes, i.e. deletes the whole record it holds on you. For that purpose, this message will include your NHS number, so that other bits of data can be deleted. That is the way it works.
So the extraction from hospital records will cease as well if you opt out? Thank you.
Not on a type... Well,
for care data it would do.
Yeah.
Yes, thank you.
Type 2.
Yes, well that's still...
Right, yeah. So other forms of data will still be flowing from the hospital record as previously?
Yes.
For direct care purposes, yes.
For direct care purposes. Thank you. Right. David, I think you had a...
I've got one very last question I have. What issues still need to be resolved before the data collection can begin in the pilot areas?
So just to repeat again for the record, and actually what I'm going to do, if it's okay, is send the caredata advisory group's minutes and papers are published, and they recently considered, as did the programme board, a paper on planning principles, i.e. the preconditions that need to have been met before the extractions can start even in the Pathfinder areas. So just in case I miss anything, I'll make sure you've got that. But essentially, it boils down to the Information Centre Code of Practice being published, regulations on the Care Act being published in terms of how CAG will operate, etc. The opt-out, actually no, what was it? Variety of other things. Sorry, I've just forgotten. So I'll send you the paper. There are a number of them, and if those are not met, then the programme board has determined that we should wait until they are met. So I can be explicit about what those are.
Thank you.
And in terms of the public's concerns, do you think there are any other issues that you wish to comment on? Are there points you'd like to comment on that you haven't been specifically asked this afternoon?
Well, I think that one of the reasons why I think there is, genuine public concern about this idea that, as Rosie said, somehow millions of health records are being dumped. We're not being accessible enough about the way in which the benefits case is made for people. And so one of the things that I feel very strongly about is that we need to be very intelligent and clear about making that benefits case, not just in terms of the way in which a local health service community can plan services in the future, but really directly about how this can support GPs right now in, for example, determining which older, frail people in my community right this minute have not yet gone to hospital with emergency admissions but are at risk of doing so, and how can they be supported and help the GP identify those people, because we're able to produce this sort of linked data. So one of the things we haven't discussed really is the benefits case, and I'd just like to say to you that one of the things we'll be working on really hard, and insights and contributions gratefully accepted, will be to try and make sure we're really clear with people about the direct benefit to them and their families in relation to this data improving the quality of local care services.
I think there's just one. I think there's a couple of other issues which we are very concerned about that CAG should address as soon as possible. There is a considerable concern, I think a very real concern about, for example, the linkage of clinical data with data held by other government departments, not least HMRC or benefits payments and so forth. I think that needs to be addressed directly by CAG. But we need that absolutely clear, and I'm also very concerned about that being done at a local level, because it gets much more. The impact potentially in a local community level is much greater, and so I would wish to have guidance on that. I wish to have guidance on the issues of commerciality.
So, in other words, if you get requests, say, from the DWP for data,
we've never
never had that.
Never done that.
Do you feel
I'm particularly concerned about at the local government level. If there is real fear, real worry by people, I think is perfectly realistic, not realistic, but perfectly understandable, about, for example, the linkage between the healthcare data and your housing benefit or so forth. And I think one of the issues around social care integration, for example, is understanding how we control that in the most effective manner.
Yes.
How we get the benefits of integration without potentially worrying people sick about the fact this might have an impact on their benefits payments. And that I think we need to have very clear clarity.
Yeah, I think we should opt out.
No, I don't think we should opt out.
Oh, I do.
The benefits of opting out are enormous.
You can't be trusted. Sadly, you can't be trusted.
Well, Rosie, I don't... Sorry.
Expressing an opinion.
It's an opinion, yes.
Yeah, absolutely.
Is there a question?
Yeah, there is a question. Why would I, as a Member of Parliament, go out there and tell people that this is a really good thing and will benefit them, their families, their communities, which is what it could do. I absolutely believe in that. When you guys have made or whoever you want to blame, have made such a mess of it so far, and now we're going to talk about the benefits. Well, some people's insurance policies have already gone up. One of my constituents has had it doubled, and you say it can't happen. And why would I go out and do it? The answer is, you're asking me to tell them they're going to get this opaque benefit when their personal information may be used in a way they wouldn't want to.
Right. So I think
I'd like to, if I may, Chair, just ask you one last thing. In terms of this issue is hugely important for the healthcare of the nation, and there have been issues in the past, and Mr. Kelsey particularly, you've identified with your experience where we're going in the future. I mean, how greater challenge do all three of you regard this in terms of your experience and work? Where does this rate on the scale, and how important do you think it is? I mean, I've expressed an opinion in terms of healthcare for this nation.
I will not be opting out because I believe that the minimal risk of my record being identified is far outweighed by the personal health benefit to myself, my family, and my community. It seems to me to be clear that the other issues that you will be grappling with over the next few years about the impact of an ageing population, the fiscal issues that the NHS face. If we are to properly redesign health and social care, to do it in a way which is integrated and which benefits local communities and whole health economies, we can only do that if we have a better understanding of the real flows of people, the changes in disease burden, and what works, what actually works, what those outcomes are, and that we bring down the variation that you've quite rightly identified and improve outcomes overall. And I think we can only do that with data, with all the risks, all the issues as we learn in going along this path. But as a patient and knowing what I can access through my smartphone now, I want the NHS to keep up with that. I want it to be the guardian of my data. I think part of my report is recognising and owning up where that has not happened in the past and striving to ensure that we do it better in the future.
Thank you.
I'm saddened by some of the comments that we made this afternoon about lack of trust and also the impugning of our motivation. I think that's disappointing. I only took on this job and its associated pain and grief because I fundamentally believe, after 30 to 40 years of working with the NHS, that we have a once-in-a-generation opportunity to get the technology and the data structures right. If we don't get it right in the next few years, then we will have lost the plot. We made a big mistake over the last 10 years. We have a once-in-a-generation to get it right. I'm absolutely clear that we have to engage the public in an open debate about the balance of risks and benefits. There will always be risks about data. There was risks when you had a Lloyd George envelope. They got lost. They flew. They went all over the place. There will always be risks. Those risks and the benefits are both enhanced by the technology. We have to find ways of ensuring that we can use the best available technology to provide the best available health and social care and carer-delivered care, not just the NHS, it's for the whole system as a whole. We have the potential technology to do it, but we have to find the socio and cultural ways of which we can secure the support of professionals, carers and staff to do it. And we have a once-in-a-generation to do that. And personally, I am completely committed to do that, and I know my board is as well.
Mm-hmm.
I just think we have a very big job to do, and I hope you'll hold us to account for delivering it.
Thank you. And would you agree that if people want to snoop on your personal medical records, there are already far easier ways for them to do it, and that's an ongoing task?
One of our great concerns is the technical bit actually is simple. The real problem is for someone blagging their way into the A&E department.
Can somebody tell me how somebody can get to medical records now, in that case? The chairman's just said there are easier ways to get medical records. What are they?
I think we know that there are some instances in which, for example, the newspapers have posed as people who they are not to ring up the secretary or the receptionist in the GP practice.
One of the things that we are undertaking on behalf of the Secretary of State is we're going to start a progress of penetration testing and social engineering testing across the system as a whole, because we are extremely concerned about the human factor here, which I think is potentially more worrying than the technical aspect.
Thank you all very much. Let me just give you a clue. People didn't like the Department of Transport selling their information, and that was only their address from their car licence plate. You guys should have had a better clue about what you were doing with their personal medical information.
Thank you very much for coming this afternoon.
Committee Room 8, Sound.